guys. Thanks for joining me. We're going to talk a little bit about postoperative CABG management. Post-cardiotomy care is very important to us here at Cooper. Our medical intensivists provide support to our cardiac surgeons managing all of the post-cardiotomy patients here. I think that it's a little bit unique, but also very important for medical intensivists to build a systematic approach to post-cardiotomy care. There is a growing need and desire for well-trained medical intensivists to extend care to the CT surgical ICU. And with that being said, you all should learn how to build an approach to specific post-cardiotomy surgical cases. If you're going to pick one, I would go with the CABG, right? Since it is the predominant surgical case that you're going to be presented with. And when I talk about building a systematic approach, what I mean is identifying patients at risk, so risk stratification, both pre-op and intra-op risks. The intraoperative technique is very important for you guys to understand. Even if you solely have a medical background, knowing what the surgeon did in the operating room will help you identify medical causes for complications and separating them from mechanical causes of complications. You have to have some understanding about the marriage between patient and bypass machine. Postoperative or perioperative complications should be in the forefront of your understanding and approach, and then an appreciation and dedication to things that drive best outcomes. So we're talking about not just in the immediate postoperative period, but when they leave your ICU and are discharged home alive. So if you know me, before we can talk about where we're going and where we are today, we have to appreciate a little bit about where we came from. So William Heberden, British physician, 1818, was the first to describe angina. When I talk to medical students, I always ask them, well, what is angina? And they'll say, oh, it's substernal chest pain. As originally described, angina was this sensation of anxiety and strangulation, which makes a lot of sense when you look at other diagnoses like Ludwig's angina. Has nothing to do with substernal chest pain, but more to do with the sense of strangulation. I thought it was fascinating that back in 1818, he was able to tease out the fact that this sensation of anxiety and strangulation had a strong prediction with extreme danger, right? No kidding. Adam Hammer, 1876, was the first to sort of outline the pathophysiology of coronary disease and MI, right? He was able to tease out that angina, as described previously, is a sensation of perfusion oxygen delivery mismatch, right? This leads to myocardial infarction or damage to the myocardium, and is likely related to progressive either atherosclerosis or thrombosis of coronary arteries. Fascinating. This is 1876, right? Years later, people were treating lice with gasoline. You're still treating mercury. You're giving mercury to patients with syphilis. Like you're sticking people in hydroelectric baths and you're shocking them, right? For a number of ailments, all of which sound crazy, but were happening long after this guy actually teased out the pathophysiology of coronary artery disease and MI. It's fascinating. Fast forward, Alex Carroll, Nobel laureate for his work in arterial grafting, was one of the first to describe how we could use an internal memory artery to bypass coronary blockages and provide support. Now, we weren't really able to do this necessarily at the time because you weren't able to perform surgery on a non-beating heart, right? Arthur Weinberg, in 1950, because we weren't able to perform surgery on the non-beating heart, took the internal mammary artery and actually implanted it into starving myocardium and allowed it to sort of bleed through and support that myocardium, which I thought was fascinating. But for all of you ECMO enthusiasts, none of us would be where we are today without this couple. So this is John Gibbon and his wife. So you guys should be very aware with the advent of the heart-lung machine and sort of its evolution to ECMO mechanical support that we see today. And like all great, innovations in medicine, you're usually impacted by some sort of adverse outcome that you had in practice. And for John, when he was an intern, he was caring for a young woman post gallbladder surgery who developed massive PE and died. And he asked himself, there's got to be a way that we can provide, heart and lung support to someone mechanically in order to rescue them from a complication like this. And he worked alongside with his wife and came up, with the first real example of the heart-lung machine, and was able to do a number of cardiac surgical procedures that were never able to be done before. And then you fast forward to Sebastian and Favalero. Favalero probably most notable for utilization of venous grafting and the first successful bypass grafts, and then from there sort of off to the races. And because of the impact of CABG surgery, right, its life-saving impact and its inherent risks, it has been the most studied medical intervention of the modern era, right? And because of that, CABG is also one of the safest cardiac procedures performed, right, with an all-cause mortality around 1.8%, right? And this is what we're going to talk a lot about, how we build our approach to all the data that's come from this in the past. And still, even with the advent of PCI and high-risk PCI, we really haven't seen much of an impact on the need for surgical bypass grafting. And still, somewhere between 350 and 500,000 patients undergo coronary artery bypassing every year. And the majority of all cardiac surgical cases, and I sort of highlighted this earlier in the talk, are going to be CABG, right? Whether it's isolated CABG or is CABG in continuum with valve repair. This is what you're going to see. So if you're going to build an approach to one of these patient types, this is the one. Before I jump into my approach, I have to say something about on-pump versus off-pump CABG. I mean, it's very attractive to be able to do surgery on the beating heart. When we first were able to prove that it was, effective and that patients could survive surgery absent cardiac bypass, because the thought was you could avoid a lot of the morbidity that we saw with bypass, like the systemic inflammatory response, platelet activation, aortic cross-clamping, risk for stroke, right? We thought that it was probably neuroprotective. When studied head-to-head on-pump versus off-pump CABG, by and large, there was a trend towards higher long-term mortality in the off-pump group, with higher need for revascularization due to incomplete revasc or worsening graft patency. A lot of this has to do with the inability to get distal, on the beating heart. So a lot of these distal anastomoses, that you're able to do with more success on pump really couldn't be performed off pump. So there is a role for off pump CABG, usually set aside for patients at higher risk, due to medical comorbidities, or that's like high atheromatous burden, where they couldn't have a bypass cannula placed through their aorta. But you're still going to see the majority, 80+%, still done on pump, and that's going to be the focus of this talk today. So this is what I refer to as a service modeled approach to CABG care. So in building the approach, it starts with protecting the patient, followed by protecting the surgery or protecting the graft, and lastly, it's about protecting performance. So we'll start with protecting the patient. There's a lot of early sort of peri-op, or whatever you want to call it, post-operative complications to discuss. Our most serious complication needs to be highlighted now, and we'll talk about it a little bit more. And when we talk about protecting performance, is going to be what? And if you answered stroke, you'd be absolutely correct. So we're going to talk a little bit about the most common post-operative complications that we see in the CABG patient. So we'll start with this. I'm going to present to you just like you present to me, CABG times 2. Right? That's all you say to me, CABG times 2. Right? So you see this chest x-ray. What are you going through as you sort of think about this systematically? This is not a normal chest x-ray. Oftentimes in our CABG patients, we're not going to have normal chest x-rays. But I think it's important to highlight, you guys are super smart, but remember that you need to compare this chest x-ray with their immediate post-operative chest x-ray. I'm going to argue that, what we highlight here on top of all the tubes and lines that aren't normal for normal people, right? You have mediastinal wires, you have mediastinal drains placed in this patient, you have a left pleural drain in this patient, and you have what looks like to be a growing left pleural effusion. In patients who are post-op, effusions are pathologic until proven otherwise. Right? They are an emergency until proven otherwise. You have a large left pleural drain in this patient. Why should this patient have an effusion, right? So number one, please compare your chest x-rays to what their immediate post-operative chest x-ray. You guys look at a lot of abnormal chest x-rays, especially in the era of COVID, where you can sort of become desensitized to a left pleural effusion and somebody who may or may not otherwise be stable, right? So this pleural effusion should not be present in this post-operative CABG patient. So we're going to say this is post-op day 1, CABG times 2. Once you've highlighted that, then the next thing you need to be thinking about is, what was my operative technique? What surgery happened to this patient? Looking at this chest x-ray, I can tell you one thing, that this patient definitely has an arterial graft, right? Not just a vein graft, right? And why do I know that? Because they have a left pleural drain, right? So I know that in order to harvest, right, the internal memory, right, they have to enter the left chest, harvest that internal memory, and then connect it, and then you have to place a pleural drain. That pleural drain is there because, number one, you entered the left chest, and number two, you're going to use that to quantitate bleeding from that harvest site, and tempo of bleeding from that harvest site. So, that drain is both therapeutic and diagnostic in terms of perioperative complications. So, if you develop a left pleural effusion, it's because of two causes mainly. One, you're bleeding from the harvest site of that internal memory, or you're bleeding from the grafting site, so you're bleeding around the heart, but you're lucky enough because you have a communication with the left chest that you're going to bleed from the heart into the left chest and not just collect around the heart necessarily and cause tamponade. You could still have focal tamponade, but you have the ability to drain into that left chest. So it's either bleeding from the heart or it's bleeding from the harvest site. That's the part that you're going to need to tease out in determining what is the cause of bleeding, is there any medical reversibility here, and do I need to take this patient to the operating room for exploration, right? So LIMA harvesting, you need to know a little bit about for perioperative complication support and supporting your patient. Go down to the operating room, spend some time with these surgeons, and look at the operative note. There's really two ways to take this down. You can either take the full pedicle or you can do skeletonization. What does that mean? So the pedicle would be that you're going to take the LIMA and you're going to have it sort of encased in its natural tissue, fascia, fatty tissue, and pleura. You're going to take that whole thing down, and then you're going to graft that. That prevents you from having to dissect out the artery independently, which there was some concern, that there could be spasm or injury leading to bleeding. This is sort of the more classic way that folks are taught. As surgical techniques have gotten better, many CABG surgeons have gravitated towards skeletonization, where you leave that pedicle intact. You just dissect out the LIMA and attach the LIMA directly. Why is that a little bit more beneficial? It's more beneficial because all of that venous drainage and all of that tissue is intact, next to the sternum, and there's a decreased incidence in sternal wound infection, which is a big perioperative and postoperative cause for morbidity. So more classically taught pedicle, probably you're going to see more skeletonization. Is one bleed more than the other, thinking that maybe skeletonization bleeds more than the pedicle? It really just comes down to how good your operative surgeon is in reality, because when studied head to head, there's no difference in bleeding. But you do need to understand how we harvest the LIMA and why there's a chest tube in that left side and where you could be bleeding from. It's not just always about bleeding from the heart. You can be bleeding from the chest from your LIMA harvesting, right? Okay, here's another case. AVR CABG times 2. But that's all you guys say to me, AVR CABG times 2. Moving on, right? No. So you have an AVR CABG. So what can you tell me up front is there's a right pleural effusion, and there's no chest tube on the left side. There's mediastinal drains, trust me, they're there. You just can't see them very well. Those mediastinal drains have no output, and the patient is relatively stable, let's just say, with a drop in hemoglobin. So now you have this right pleural effusion. This is not normal. You've identified that. Let's just say it was definitely not present in the postoperative chest x-ray. So what's going on? And I think that's what's important, right? I can tell you right now that in terms of CABG surgery, this patient does not have an arterial graft, meaning that it's CABG times 2. If I go in and look at the operative note, I can guarantee you they're both vein grafts. So this is probably, let's say, AVR with a saphenous, with vein graft to the RCA and the and OM1, whatever. Why does the patient have a right pleural effusion? There's no reason to be in the right chest. So where's this coming from? CHF? Wrong, right? So this is bleeding until proven otherwise. Patient has downtrending hemoglobin. Let's say got a unit overnight. Looking a little pale for you this morning. Blood pressure is soft. Again, understanding what happens in the operating room is helpful in predicting postoperative complications, right? So, wire closure. So think about this when you have an isolated right pleural effusion. See how they're putting the needle through to tie in the sternal wires, right? So what runs right next to the sternum on that right side? The right internal memory, right? Could have an intercostal injury, but most likely you could have the wire needle go through the right internal memory, and now you're developing a large hemothorax on the right side due to sternal wire placement. Right? Wouldn't know that unless you've seen a surgery done before. Right, so bleeding. This is something you guys are going to come up against, and probably something that you think about as your number one complication. You will see bleeding, but you worry about stroke. But 30% of your patients are going to require transfusion. Only about 3% are going to require reoperation, and that's why it's very important for you to be able to tease out medical causes of bleeding and mechanical causes of bleeding, right? There's no medical therapy for a mechanical complication, but people who go back to the operating room for reexploration do worse, right? So you have a responsibility to make sure that when you send that person back to the operating room to be reopened, that there's something in there that the surgeon needs, a hole that needs to be plugged, and that this isn't due to medical bleeding from coagulopathy, right? So let's ask ourselves, preoperative or perioperative use of aspirin is going to happen in all of your CABG patients. They're going to be out on aspirin before they go to the operating room. When they come out of the operating room, 6 hours after they come out, that first aspirin better be in their body, right? Is aspirin associated with an increased risk of bleeding? No, right? Data suggests aspirin, not an independent risk factor for bleeding. What about Plavix therapy? So patients on dual antiplatelet, somebody comes in as an NSTEMI and is high risk, post-cath, has active symptoms, so has to be taken emergently for bypass graft. Plavix certainly is an about a 5-fold increased risk for bleeding in the postoperative period, especially if that patient didn't have at least 5 days for that Plavix therapy to wash out. What about prevention? Right, so again, understanding what happens in the operating room is very important. When we think about prevention, these patients get anti-fibrinolytic therapy. They get aminocaproic acid following surgery. But what about tranexamic acid? Is there any role for TXA? We give TXA for everything else in critical care. What about TXA in our post-bypass patient? Well, the answer is probably not. So it was studied for TXA in the peri-op for cardiac bypass patients for reduction in need for transfusion and all-cause mortality. There was actually a reduction in the need for transfusion. There were not any increases in the thrombotic events. But interestingly enough, there was a 7-fold increase in seizure activity in this study, and it was the last study that I can see done for TXA in cardiotomy patients. And nobody could really tease out what it was. There was no large vessel occlusion. Again, this wasn't a thrombotic, this wasn't a stroke with secondary seizure. In a editorial written after the fact, there was some suspicion that TXA could have anti-GABA properties, leading to excitotoxicity and seizure. I have never seen seizure associated with TXA in any other TXA study, but all that being said, if it ain't broke, don't fix it. So everyone's continued with the use of aminocaproic acid traditionally and not TXA. What about empiric administration of fresh frozen plasma? I give products to these guys all the time, right? So no improvement in need for transfusion or overall outcomes in FFP, right? So, in terms of bleeding risk, Plavix certainly one of them. There's other medical reasons for bleeding that you're gonna have to tease out from your understanding of the patient's history prior to presentation. Aspirin is not associated with it. TXA we don't give traditionally, and FFP there's no role for empiric FFP. Low cardiac output states, I think we're very focused on the hearts, right? So a low cardiac output state from reduced EF you will see. There's a lot of reasons to have impaired left ventricular function, right? You have cardioplegic arrest. There can be some ischemic injury or just myocardial dysfunction with stunning. This tends to improve over time. Very important for you guys to pay attention to your intraoperative TEE that your cardiac anesthesiologist will perform at the end of the case to give you some insight and whether or not there is a change when you're seeing them post-operatively. There's a lot of other reasons to have low cardiac output states relating to low plasma volume, accelerated diuresis. Sometimes these patients are very cold when they come out, so they can have a cold diuresis, so it can be a volume issue. You can have high afterload in the setting of myocardial stunning, so hypertension we tend to treat. That's why a lot of times you'll see these guys immediately come out and go on a nitro infusion to treat hypertension because of the afterload effect causing a low output state. Arrhythmias, whether it's just flicking into atrial fibrillation, the loss of your atrial kick can generate a low output state. So there's a lot of reasons for low cardiac output states that aren't necessarily related to left ventricular squeeze, but you're going to see a low output from low EF commonly in your CABG patients. And there's reversible causes, there's non-reversible causes, and there's a lot of things that you're going to have to work together with your surgeon and your cardiology team to optimize so that patient does well. You'll see patients come with preoperative intra-aortic balloon pumps. So they'll put a balloon pump in during surgery, so it has been shown to improve survival in high-risk patients undergoing CABG, right? So patients with left main coronary artery stenosis, it's an indication. With class 3-4 heart failure and low EF, it's an indication. For diffuse coronary disease requiring 3+ distal anastomoses, support with an intra-aortic balloon pump shows a reduction in mortality, and for patients with refractory stable angina. So you'll hear them talk about the balloon pump is placed for support or it's placed for anatomy. You can understand for anatomy having a lot to do with this left main disease, with these arterial stenosis, for support for patients with low EF, right? Just understanding guidelines and why they'll come out. A lot of times these balloon pumps will only be needed to be maintained for a few hours, and then they can be discontinued. Vasodilatory shock, again, this is something that's right in your wheelhouse as a medical intensivist. Distributed shock, that's your home field advantage, right? Identify it, support it, and talk openly about your team about what interventions you think may be beneficial. There's a lot of reasons to develop sort of distributed physiology. Many of them are thought to be related to either ischemia reperfusion injury or most likely related to the marriage between patient and bypass pump and the systemic inflammatory response that comes with that. High amounts of interleukin 1 and interleukin 6 being produced, right? that impacts, release of tumor necrosis factor, which goes to the locus coeruleus of the hypothalamus, and from there it impacts the hypothalamic pituitary axis, right? And you have a down regulation or desensitization of adrenal receptors, and this, in marriage with this pro-inflammatory state and release of nitric oxide, it's like the perfect setup to have vasodilation and a lack of response, right? And then you have, nitric oxide species, decreased intracellular calcium, myosin dephosphorylation, vasodilation, and then your upfront response is like you dump out a bunch of adrenergic hormones, norepinephrine, vasopressin, angiotensin 2. You dump that out, then you become hormone depleted. So then you got vasodilation and hormone depletion, and then you're in big trouble. And risk factors would be patients who are warm on bypass, might be, being warm on bypass might highlight the fact that there is inactive inflammation. Patients on antihypertensive medications preoperatively, talk about beta blockers, we talk more about ACE inhibitors or calcium channel blockers, and then really long pump runs, really long exposure to the bypass circuit puts you at high risk for this vasodilatory shock. So identify it, index greater than 2.2 SVR, less than 800, and then what are you going to do about it? There's a lot of different approaches. Catecholamines are going to be your first approach, right? You're going to give norepinephrine. You can utilize vasopressin, which will increase tone and decrease maybe decrease nitric oxide production. I think it's interesting. I've seen in some CT ICUs they have a protocol for vitamin C, thiamine, and steroids. Not as commonly used, but there's some thought behind vitamin C being a cofactor for catecholamines, thiamine similarly supporting vitamin C and decreasing lactate production, and the glucocorticoids similar to what we use for SIRS and sepsis is their impact on NF-kappa B and the systemic inflammatory cascade. I don't see it as much in glucocorticoids independently when studied, not super helpful, and certainly can put you at risk for hyperglycemia, which we'll talk about. Not something we want in our post-cardiotomy patient. Methylene blue, you will see more commonly used as a nitric oxide scavenger to increase vascular tone. Hydroxycobalamin, similar, B12, right? But similar mechanism of action to your methylene blue. And then angiotensin 2 is something that you can utilize here at Cooper. You're going to see the utilization of catecholamines, vasopressin, methylene blue up front. We don't carry angiotensin 2 here in the hospital. There's a couple of really nice algorithms for the approach of vasodilatory shock, so I think that it would be wise to take a look at some of these. Utilization of catecholamines, vasopressin up front, methylene blue. If you can't use methylene blue, why wouldn't you be able to use methylene blue? Is like a step one question. Patients with G6PD deficiency will develop what? Hemolysis, right? So you don't want that to happen, right? So if you have any inclination that you can't use methylene blue, you could jump down to something like angiotensin 2 or hydroxycobalamin, okay? So think about that. All right, the protamine reaction, different than the vasodilatory response, although it is still distributive physiology. Often this is more of like an anaphylactoid reaction to protamine, as we give protamine to reverse high-dose heparin for our bypass patients. You get distributive physiology. You can see sort of spikes in these PA pressures in the development of non-cardiogenic pulmonary edema. They can develop bronchospasm, very similar to what you'll see in the anaphylactoid patient. They may develop urticaria. So you'll treat them, similarly with antihistamines and potentially corticosteroids. Patients at risk for protamine reaction, we should talk a lot about patients with fish allergy back in the day. Remember, protamine was derived from salmon sperm. Now it's synthetic. It's a synthetic derivative, so it might not be that impactful for people with fish allergy. But there is one patient population due to exposure that are at risk for protamine reaction. That's what? Patients who are on NPH, right? The P in NPH stands for protamine, so it's somebody who's had exposure in the past and then maybe, with subsequent exposure could develop an allergic reaction or anaphylactoid reaction. So again, temporally, you may see this in patients. Patients who will have vasodilatory findings are going to be in the early perioperative phase, and same thing with this protamine reaction. So sometimes it's a bit of a challenge to differentiate the two. That's why exam is very important. Risk factors are very important. Atrial fibrillation you're going to see is in a third of your CABG patients. You're going to see in 2/3 of your valvular patients, right? And as you're taught in medicine, rate versus rhythm control. During race data says rate is as good as rhythm control and probably less complications. Not in your post-cardiotomy patient. Okay. Ingrained in me very young was AFib begets AFib. You want to get your patient out of AFib. They weren't in AFib, and because of a number of surgical factors like inflammation and intervention, they could develop AFib. You don't want them to lose your atrial kick. You don't want them to stay in AFib and need anticoagulation, so get them out. So, beta blockers are good for prevention. Sotalol, amiodarone have all been studied, all sort of equivocal in terms of preventing AFib. That's why you want to get your beta blocker on post-op day 1 if the patient can tolerate hemodynamically. If they go into atrial fibrillation, you can bolus them with amiodarone in an effort to convert them back to sinus rhythm. Sotalol not used as often due to a higher association with bradycardia or hypotension. Atrial pacing in and of itself has never been shown specifically to prevent or maintain sinus rhythm, although you'll have surgeons based off of experience who still will want to apace their patients. IV magnesium in a systematic review did show a reduction in AFib, so especially your valve cases, you're going to see your surgeons they're going to want IV mag given in the perioperative period. Statin therapy, the ability, starting your statin therapy on post-op day 1, also important not just for long-term graft patency, but important for preventing AFib. So like we said, rate versus rhythm control, your target is to convert them back to sinus rhythm. If they maintain an AFib for 24 to 48 hours, you will be forced to anticoagulate these patients and maintain anticoagulation for 4+ months. So they'll obviously won't see you anymore. They'll see their cardiologist and their cardiac surgeon post-operatively. But just understand, AFib begets AFib. The longer you allow them to stay in AFib, the harder it's going to be to get them out of AFib. Protecting the graft, right? You need to understand a little bit about what got attached to what, right? I was fascinated. I didn't even know there were this many types of arterial grafts until I read, a textbook on cardiac surgery. I'm very familiar with the internal memory, occasionally a radial graft. I've never seen an ulnar graft before. I've never seen a gastroepiploic artery graft. I've never seen a splenic artery graft. Never seen an inferior epigastric artery graft. I guess they happen, or else they wouldn't be in this textbook. But pretty wild. But just know where they harvest from. Obviously internal memory grafts they're longer, they're easier to connect. Come right off the subclavian. Flows are good. They stay patent longer. Radials maybe not as great in terms of how much you can get in patency over time. Talking to cardiac surgeons throughout my experience, they try to stay away from the ulnar. They don't like to harvest the ulnar because they actually believe that the ulnar probably provides more support to the hand than the radial. So all these things I think are important when you think about what was taken and what was applied where. So here you go. Post-op day 1, patient complains of chest pain. Nurse calls you to the bedside. Here's your EKG. What are you going to do? So what do you see? So you see ST segment elevations, right? And from a medicine standpoint, you start to get chest pain, right? So this is a diagnostic dilemma that happens in post-cardiotomy care. So they all have chest pain. A lot of them have EKG changes, and we're going to talk about that. What are EKG findings, or what are findings suggestive of acute myocardial injury or acute graft failure versus what could be inflammatory mediated? And just understanding that acute graft failure during hospitalization is pretty rare. It's exceptionally rare to see it maybe post-op day 1 into 2. I mean, these patients generally will not spend more than 48 hours in your ICU. You still have to have an approach. And just to be clear, there's no perfect way to delineate this, but the most important thing is for you guys to communicate with your surgeon and with your cardiologist so you guys can come together to identify an acute graft failure, which would be, the most concerning finding versus what is most likely pericardial inflammation. And in this EKG, you see diffuse ST segment elevations in a patient post-op day 1 who's otherwise hemodynamically stable. There's a high likelihood that this is pericarditis. Now, it can get real tricky. Sometimes it's not as diffuse as this. And, for patients who go for off-pump CABG when they're in that little like octopus suction vacuum thing to hold the heart in place, you can get focal pericarditis because of these little suction hickeys. And you can have focal ST changes that are really going to make it even harder on you and create even more chest pain. Again, conversation, I think, is really important. There is a diagnostic dilemma in this. Cardiac biomarkers should be expected to be elevated in this patient population, right? Almost all of them will have elevated troponins and CKMBs, secondary to bypass and cross clamping. They've done studies where they've looked at cardiac MRI in patients with elevated biomarkers post cardiotomy, and they've had no evidence of ischemia. So it's expected. Now your job is to be able to tease out, whether or not you should order it. And by and large, when you order, you're going to get yelled at for ordering biomarkers because you expect them to be high, right? That being said, if you have a high clinical index of suspicion for active ischemia, and again, it starts with clinical index of suspicion. Clinical index of suspicion. This is why experience and conversation and discussions are so important. If you have very high cardiac biomarkers, well, then maybe there's myocardial ischemia. Talked a little bit about 5 or 10 times the upper limit of normal. Still, not a great tool for evaluating, not like it is in traditional medical ACS, right? Okay, transesophageal echocardiography, probably more sensitive at identifying MI in these patients, more than EKG. And it makes sense if you can identify progression of wall motion abnormality or new wall motion abnormality that would be consistent with distribution of ischemia, then yeah, maybe you can say that there's a lack of perfusion in this area and we might need to evaluate. We use transesophageal echo pretty regularly. Remembering that there are regional wall motion abnormalities that you can expect post-cardiotomy, especially decreased septal motion, as there's like a change in geometry due to the surgical intervention in and of itself. And the impact of pacing and all of these things can lead to wall motion changes. So you just, again, clinical index of suspicion comes with experience and conversation and the inclusion of the entire team when it comes to the evaluation of acute ischemia. ECG findings or EKG findings, ST elevations probably aren't nearly as helpful as new Q wave formation, right? So if you see the development of new Qs, then I would probably be a little bit concerned that something's been going on, right? But isolated ST elevations, or at least diffuse ST elevations, are expected. So it can be tricky, right? 15% you're going to see elevations, 15% you're going to see depressions, no correlation with outcome and acute injury. So a diagnostic dilemma, right? So post-operative graft failure is not common, but what you're going to see in the ICU is going to be largely mechanically driven, either like kinking or a mechanical failure at the level of the anastomosis. These patients might not have like sort of classic anginal pain and whatnot. You'll probably see hemodynamic compromise or changes in LV function, and you need to be careful if you sort of take your natural algorithmic approach of like beta blocker, morphine and nitroglycerin, because they might end up in real trouble. A lot of these things won't be terribly impactful when you have a kinked bypass graft, which is different than chest pain or angina related to atherosclerotic burden of a coronary artery, when you have something that all of a sudden just got kinked off, your sort of medical interventions are not going to be super helpful. Really, it's about identification and taking that patient for early PCI, right? Vein graft failure are going to be more common than arterial graft failure. There's a number of things that we can do to try to limit the potential for vein graft failure. There's a lot of risk factors that are at play, but remember, like most of what you're going to see in the ICU are going to be mechanical issues related to kinking or size mismatch, and it'll be a little bit different than your traditional medical presentation for ACS. And graft related factors, the LAD is going to do much better than the diag, than the circ, than the PDA. So just know where these grafts end up going. Similarly, for arterial graft failure, less common than vein graft failure, and usually due to some sort of mechanical obstruction or kinking. And you would, your approach to this is going to be angiography and PCI. So, what you end up seeing in terms of graft failure is going to be failure at the anastomosis. Acute occlusion you'll probably see a little bit later in the periop phase. If you ask my opinion, in the few times I've actually seen this in my life, probably closer to discharge if you're going to have acute thrombosis. But if you're going to have kinking, you're probably going to see that earlier in your ICU stay. All right, so that's protecting the graft. So lastly, we got to talk about protecting performance. And it's not just about looking good on paper. It's because you do the things that drive outcomes in your patients, right? So there's a lot of quality measures that we're all held accountable for.
Cold blue, North 9. Cold blue, North 9.
Okay, so there's a lot of quality measures that we're held accountable for. So we're going to go through some of the ones that I think are very important and some of the ones that you can help support so that your cardiac surgical patients do well and your cardiac surgical program does well. Okay, surgical reexploration, we talked about this a little bit. You have a responsibility to identify patients who need to go back to the OR and be explored, and making sure that there's not a medical cause for this, that this is a mechanical cause that your surgeon can plug a hole, right? We see bleeding, expect bleeding. Criteria for bleeding for reexploration, you think about bleeding about 500 mLs in the first hour, 400 mLs per hour for 2 hours, 300 mLs per hour for 3 hours, or a liter out over 4 hours, are all sort of agreed upon reasons to take people back to the OR and explore, provided that you've done your best to support medical causes of coagulopathy and bleeding. Each one of you will have a different sort of CT surgical escalation protocol, so I recommend that you spend time reviewing your CT surgical escalation protocol so you know who to contact when and how to advocate for what you need. Sudden massive bleeding, obvious signs of tamponade are good reasons to surgically explore patients. And then, cardiac arrest with active bleeding would be a time to open the chest. When you take people back, again, this isn't that common. We think about 3%, but we know if you take them back, they're going to do worse. So you better take them back, and there better be a reason to take them back. Sites of bleeding, at the graft and anastomosis and CABG, very common. Remember that, like we talked about, that IMA bed, right, where you harvested and how you harvested. Cannulation sites, not as common, in the aorta or the atrium. People do worse when you take them back for obvious reasons, but also delays are a huge problem. Median time is about 8.5 hours. You want to try to be slightly better than that when arriving at a decision. Losses can be high, and then risk factors, obviously, age and comorbidities, I think, are important. Multiple graft sites, 5+ grafts is an independent risk factor. BMI, I think, is an important one. We talk a lot about large patients. It's the tiny ones that are going to cause you problems in post-cardiotomy care. Oftentimes they don't have a lot of chest to bleed into, and they don't have a lot of space to work inside of. So I'm sure dexterity probably has something to do with that. I'm a medicine doctor. I don't do surgery. I'm just assuming, right? But tiny people don't do as well. All right, prolonged intubation. This is your wheelhouse. Get these people off the vent. We know that prolonged mechanical ventilation drives worse outcomes, right? Certainly does in the post-cardiotomy patient. For patients have risk factors for needing to stay on the vent longer, like longer bypass time, heart failure, renal failure, underlying obstructive lung disease. Try to optimize this. Get these people off. A pulmonary complication is defined as anybody who stays vented for greater than 24 hours. You have a responsibility to try to wake them up, shake them up, and get them extubated. Postoperative renal failure. If you want to highlight one organ system that is not allowed to go down in the postoperative period, it's kidneys, right? People who develop renal failure do bad, right? They don't survive heart surgery. Postoperative renal failure is defined as a creatinine greater than 4 or 3 times an increase in the pre-op hemoglobin or the initiation of new dialysis. Certainly, it's a metric for quality and performance, but it highlights something that we need to be very careful of in prevention. So there's a lot of strategies to this. The most important strategy is maintain perfusion to the kidney and prevent hypervolemia and prevent hypovolemia. And again, for the medical intensivist, this is where you nerd out, right? So, avoiding nephrotoxic agents, optimizing intravascular volume status, through a variety of ways. Some patients have the luxury, if you have a valve and a CABG, you're probably going to have a PA catheter. Otherwise, you're going to be using ultrasound. Trying to optimize forward flow, is a prophylactic strategy that some surgeons will take. You'll see them use furosemide, renal dose dopamine, and phenoldiazepam in order to make patients pee. Now, that's it might work, right? But what I would say is, the successful conversion of oliguria to peeing, to diuresis, I guess is what I should say, does not result in a more mild form of renal failure, right? So getting them to diurese is not the right answer, right? Getting them to diurese because you treated the underlying cause for oliguria is the right answer, right? So in terms of renal dose dopamine, the impact of low dose dopamine, like 0.2 to 2 micrograms per kilo, and its impact on plasma blood flow and perfusion to the kidney and diuresis, mechanistically makes a lot of sense. It's never been shown to be beneficial necessarily in our postoperative patients. Although you'll still see some surgeons when the urine output starts to drop and the creatinine starts to rise, advocate for the use of renal dose dopamine. Similarly, phenoldiazepam works the same way. So you just, the evidence isn't there to necessarily support the use of this, but that's why it supports the use of a trained medical intensivist, right? Find out why these kidneys aren't working. Use the tools that you have in order to maintain perfusion and optimize volume status. Stroke is probably going to be is still the number one feared complication. With the use of epiaortic ultrasonography and a single aortic cross clamp, we've really reduced the incidence of postoperative stroke. The mechanism why we think most of these patients have strokes is because they end up, embolizing atherosclerotic plaque. Which is why most of these strokes that we see are not necessarily focal, dense strokes, but are bilateral. So you can reduce that by looking at the atherosclerotic burden and using ultrasound for placement of your aortic bypass cannula, and then a single cross clamp. And again, this can be difficult sometimes to elucidate because these patients, they come out of the OR and they're not reversed, so they're not moving and they're not doing anything, and we may not catch this for a day or so. So you really have to be tuned into what their risk factors are, and identifying it, because there is a role for intervention, and that's why this conversation has to be had, in terms of evaluation and intervention, has to be had with your surgeon and your neurologist in real time together. That's all I'm asking of you guys, is to have that conversation with your surgeon about what your concerns are for acute stroke, and contact your neurologist so that you can hopefully be able to intervene and rescue. Deep sternal wound infection is certainly something that we worry a lot about, as these patients are at very high risk and have very high morbidity and mortality. So reexploration is an independent risk factor for developing a sternal wound infection, as well as lack of glucose control in the perioperative and postoperative period. So really important in terms of prevention. Postoperative blood glucose, I'm going to hit on it over and over again because this is an area where you just cannot fall out because you have the ability to control this. These patients are on one-to-one nursing care. They come out on insulin infusions. And patients who have sustained blood glucose is greater than 250 are at a 10-fold increased risk for complications. It seems silly, but it's very impactful. So glycemic control reduces morbidity, mortality, wound infections, length of stay, and overall survival. Get those glucoses to their appropriate levels and maintain them there. That's all I'm going to say. Antimicrobial prophylaxis. All these patients are going to receive operative antibiotics. There's no data to suggest prolonged antibiotic exposure to continue antibiotics for longer than 2 days. I bring that up only to highlight, some of these concerns for deep sternal wound infection, but you won't see prophylactic use of antimicrobial therapy in these patients. Beta blockers are very important for patients who undergo isolated CABG, so you have a responsibility on post-op day 1 to start beta blockers as long as those patients can tolerate it from a hemodynamic profile standpoint, and if they can't, you have to document why, right? You couldn't start your beta blocker, not just don't order it, document why it couldn't be initiated. Patients who get beta blockers live longer. Patients who get beta blockers are at a reduced risk for atrial fibrillation. There's a lot of reasons why postoperative beta blockade is so important. Antiplatelet medications, again, very similar, reduces the risk for death and ischemic complications. We're all starting aspirin 325 within 6 hours. Anti-lipid therapy, I'm going to hit on it again. You can't forget to start your statin therapy. It relates to all-cause mortality as well as the lifespan of your CABG grafts. Okay, so you have a responsibility to start your aspirin, your beta blocker, and your lipid therapy better be on board before that patient rolls out of your ICU post-op day 1. And that's my service modeled approach. So just sort of to reiterate, we have an approach to protecting the patient, protecting the graft, and protecting performance. And if we do those things, we can support our patients who undergo CABG surgery, and we can support our surgical team, which is our role as intensivists, to provide intensive care and support for best outcomes. And with that, I'm all done. I appreciate your time.